Any questions about that? Okay, so we're moving forward into joint structure and function. Talked about muscle and the impact on muscle and movement last week. This week we're looking at joint structure. We're looking at the why did I not progress? Oh, I know why. Sorry, let me get back to my... Okay, so our objectives with this lecture are to look at the different joint types, and you guys have talked about those. I'm just presenting them again so we have the same nomenclature, but you talked about it in anatomy, so we're not going to bore you with all of that. We'll just kind of make sure we all understand the terms and move on. We're going to look at the different types of connective tissue, what holds the body together. That obviously is going to have an impact on movement and how a person moves and how they heal and how they respond to stress. We're going to look at the key components of connective tissue. We're going to look at what load does to it, what stress does to it, what the strain is on tissue. The different types of connective tissue. We're going to get into arthrokinetic movements. This was not talked about in anatomy. I talked to Chad and he did not talk about this. So we are going to get into the arthrokinematics of movement. So what does one bone do when it moves on another? Osteokinematics is the actual movement of the bone. Arthro is what's going on at the joint. So that's a distinction you're going to need to make sure you're clear on. And then just quickly, what implications of immobilization on the body structures. So our body tissues, our connective tissue, responds to the stresses that we put on it. So the form is going to follow the function. If you are, if you're an athlete, if you're a gymnast, your joints are going to look very different from someone who's a sumo wrestler, right? Because your demands on those joints over time and repetition are different, so your body's going to respond to those stresses. So we can actually look at those tissues and tell what kind of stresses have been on them. It includes the composition, so you're going to change the composition of your connective tissue. Your bone is going to respond to stress, your ligaments, your tendons are going to respond to stress, and they're going to change and become better at what you ask it to do, usually. Sometimes it's negative, sometimes it's a wear and tear that becomes an arthritis. And all human joint structures respond to this. They're typically mechanical, but it can also be a response to a mobilization or some other inactivity or training stress that you put on it. So this foot on the left does not look a thing like my foot, right? Because this prima ballerina has stressed and stressed and stressed her foot until it can get in that position. Is that normal plantar flexion? No. So she has had to put stress on her body along certain lines in order to accomplish that sort of motion. And these, I'm supposed to use this. These bumps here on the heel are called pump bumps, typically, or Haglund's deformity. If you're a runner, you probably have some of these. It's basically the hypertrophic growth that occurs from the Achilles tendon, the stress on the Achilles tendon from running. So that is also a response to stress. The picture, is this normal external rotation of the shoulder? No, but in order to throw the ball faster, he has adapted his shoulder to have more external rotation to increase the velocity of the pitch. So all of these experts and people who do something a lot have had modifications to their body to allow them to do those particular things. That's why I can't throw like one of the famous. I don't even know pitchers. I shouldn't even admit that. I'm a football gal. Okay, so there are different classes of connective tissue. This is just giving you an overview. Connective tissue is a huge topic, right? If it's not muscle, basically it's connective tissue, and muscle has connective tissue within it. So we're looking at things like cartilage, which we're going to talk about a lot. Bone, we're going to talk about some. Blood is a connective tissue. And then we've got, tendons and ligaments. So those are the primary ones that we are going to touch on. I almost took this stuff out. Ben and I had a conversation about how much I need to talk about the composition of connective tissue. But I think when we talk about stress and strain curves and all that kind of stuff, I think it helps to understand the composition of a tissue to see how they respond to stress. So we're going to just review this. This all should have been covered in physiology, cell bio, all those things. This should be a big redundancy. So I shouldn't have to dwell too much on this. But connective tissue is made up of fibrillar components or fibrous proteins. Those are the ones that give it some tensile strength. Blah, blah. See, I need to walk. Tensile strength. So we're talking about collagen. We're going to dwell on type 1 and type 2. There are many more than that, but what we care about is type 1 and type 2. And then elastin is also a fibrillar component, and it's important in body movement and structural response to stress. Then there's all that muck that holds it all together outside the cell, and that's called the interfibrillar components, or the ground substance. So you've got these fibrous proteins, and then you've got this gel that kind of bathes it all and surrounds it all outside the cell. GAGs or glycosaminoglycans, water and solutes. So the amount of GAG that something has determines the water content. Water is very important in our structures for responding to forces and stresses and things like that. Dr. Schwartz is going to talk about GAGs when you come to musculoskeletal, when we're talking about affecting tissues with manual therapy techniques and those sorts of things. And then the interfibrillar components actually determine the tissue's function. So how much water it can handle, what kind of solutes are in there, is going to help determine the tissue's function. And then you have the cells that build the cartilage and the bone. So fibroblasts and chondrocytes are also a part of the connective tissue. So this is kind of a picture of it. So you can see the cell membrane is down. The cell membrane is down here along the bottom. So this is inside the cell. All of this is outside the cells. And the different components determine what type of tissue it is. So what kind of fibrous protein, what type of proteoglycan, and how much of those. How much elastin. These little green squiggly things are elastin fibers. So how much elastin is in it tells you how much give the tissue has. So in order for cartilage to withstand compressive forces, it has to have an intact collagen network, and it has to have that GAG proteoglycan matrix. That's what helps the cartilage to kind of support compressive load. So as we lose water, cartilage is less able to manage compressive load. All right, so real quickly, the fibrillar components. This is the main substance of connective tissue. It's 25 to 30% of all protein in mammals. So a third of your protein lives in your fibrillar components. These have a high tensile strength. Anybody remember what tensile refers to? What type of stress is that on a tissue? Wayne's got it. It's the tendency to pull two things apart. Right? So a tensile strength is a tug of war on a rope. It's the tensile strength along that rope, or the tensile force along that rope. In cartilage, it's similar to steel. So if you imagine two of you standing on either side of a steel rod and pulling, that's about the same tensile strength that these fibrillar components have. That is significant. Two types we're going to talk about. Type 1, mainly responsible for the tensile strength in tissue, or that pulling along in one direction. It's what holds bones together. right? It's going to bind and support those bony articulations. Type 2 is more designed for shape and consistency. So it doesn't have as high a tensile strength as type 1. So fibrocartilage contains predominantly the type 1 collagen. And again, it holds bones together, so it's going to help guide movement. It's going to help dissipate forces that come along the bone. If someone rolls an ankle, if you get hit by a car, these kind of things, hopefully that doesn't happen. But the fibrocartilage is going to help dissipate that. There are few sensory fibers. The location of the sensory fibers is really near the insertions to the bone in some locations, and we'll talk about that as we go regionally. A very low blood supply. The nourishment for fibrocartilage typically comes from osmotic pressure. So compression on the tissue forces fluid out. You release the pressure, fluid comes back in. And these structures, we're talking about the meniscus in the knee. We're talking about the annulus fibrosus in their intervertebral discs, that labrum in the shoulder and hip, your TMJ disc. Those are the type of cartilage that are fibrocartilage. The hyaline articular cartilage is type 2 primarily. So type 2 is good for compressive load, not so much tensile load. It covers the long ends of the bones in those synovial joints. So that's the cartilage when you were in anatomy and you dissected the knee out or the end of a long bone. That whitish, gleaming, looks like, like a shiny, icy-like surface. That's the hyaline cartilage. It has low friction, so it allows easy movement between the two bones. It also is compressible, so if you have two bones compressed together, that compression helps to dissipate those forces, so it doesn't go through the bone, which is not as good at dissipating forces. And again, little to no vascular or nerve supply, so we're going to call it avascular and aneural. And no lymphatic system, so no system to remove the sewer. That's the sewer system of the body. No mechanism for that. So alymphatic in the hyaline articular cartilage. So again, the nourishment comes from that milking of the during joint loading. All right. Another one of the fibular components that's important to us is elastin. This has more give when stretched, so the tensile strength is not as high as as the type 1. But the important thing is that it bounces back. Right? It's like a rubber band. You stretch it, it comes back. There are some places in our body we want that, and some places we don't. Imagine if all of your ligaments around your knee had a ton of elastin in them. So every time you step down, right, you have no support in your knee whatsoever, right? So these elastic components are in things that need to be able to extend and come back to their previous shape. So we're talking about the aorta, right? We want that to come back to its original shape so that it can expand and contract again. The ligamentum nuchae. That one has one of the highest amounts of elastin in the body. It has to be able to stretch, but we also need it to snap back because we don't want it impeding on the spinal canal. And the Achilles tendon, look at the Achilles tendon, 4.4 elastin, it's 86% collagen. What does that imply about the Achilles tendon as far as how much it stretches and comes back? Is there much stretch in that? No. Very small amount of elastin. It has some because it has to have some stretch. But the collagen, which has high tensile strength, is predominant. So when we need the Achilles tendon to generate propulsive force, it's got high tensile strength. It's not going to just stretch and come back, right? So the different structures have different compositions. And this is what the elastin fibers do. This is their resting state. Looks like a bowl of spaghetti. And then when it's stretched, it's connected here by these little red connecting proteins. And it stretches, but then it's able to recoil. They cross-link, and those cross-links give it the strength. Okay, for bone. 2 layers of bone. Chad told me this was a struggle for you guys when you had anatomy, so we're going to pound it in one more time. You've got a dense outer layer, that's the cortical layer. You've got that spongy inside layer, that's the cancellous layer. The trabeculae, which are in the cancellous bone, lay down along lines of stress. So it's not just a jumbled mess of, macaroni inside your bone. It actually lays down along lines of stress. The bone responds to that biomechanical energy with compression or muscle contraction. So as your muscle contracts against a bone, it actually helps to lay down more bone along lines of pull. Wolff's law is what we call that. That bone forms in areas of stress and it's reabsorbed in areas of non-stress. So where a muscle pulls a lot, where Ben's bicep tendon inserts from his repetitive pint lifting, that's a pretty good bone development down there where that tendon is. But if you don't use something a lot, so if you're immobilized and you don't use your muscle as much, you actually lose some bone. So for clinical indication, if we have a person who's in a cast, let's say they broke their ankle, they're in a cast, they can't actively move their leg, but if we ask them to do isometric strengthening within that cast, that helps to keep the bone strong. So you can have that isometric pulling on the bone to do this, to accomplish that Wolff's law. Keep that bone strong when you're immobilized. So what is the implication about cortical bone being stiffer than cancellous bone? Which can withstand greater stress? Greater pushing, pulling, cortical or cancellous bone?
Cancellous.
Or cortical? Cortical? The cortical bone is denser. It's going to have a better ability to withstand the stress. Cancellous bone is like a scaffolding. So if there's a lot of stress, there's small fibers, it actually can't withstand a ton of stress. And we're going to talk about the stress and strain and the difference here in a little bit. So the trabecular bone is arranged in parallel layers. So they do lay down along the lines of stress, the pull. And the compressive loading causes hypertrophy. So if you look at this femur, this is the head of the femur and the shaft, and our body weight, right, is through the head of the femur. You guys aren't seeing this on yours. It's through the head of the femur. Right there. Right? So your body weight comes down here. That transfers over to the shaft of the femur through the neck. So that neck of the femur has to manage to transfer our body weight over to the shaft of the femur. And that's why you get those lines of stress along the neck of the femur. It's also why the neck of the femur frequently fractures. There's a lot of stress on that little bone, especially as someone gets more osteoporotic. So some of the loads that we apply to bone, tensile is pulling apart or elongation. The bone is very good at that. It doesn't typically, it doesn't typically have a problem when you have tensile strength on it. Compressive strength is pushing together, so you're compressing it or shortening it or pressing the two ends of the bone together. You can get compression fractures, so it does respond to stress that way. You could have a torsional or a twisting fracture. Young kids frequently get this. Their bones are fairly pliable still, and so if they, they're holding on to their mom's arm and they run away and jump off a curb and their arm twists, they can get like a green stick fracture. So it's a twisting torsion of the bone. And then there's a shearing. So the surfaces slide past each other. This is like being hit from the side. Bones don't respond real well to shearing force. And then we have bending. So that neck of the femur, if you think about that neck of the femur, it actually is a bending force from the body weight transferring over to the femur. So what happens in that case is you get a compressive load on the inside of the curve. You get a tensile load on the outside of the curve. So concave surface compresses, convex surface is tensile. So it's a very dynamic stress on the bone. So, in the case of the neck of the femur, what types of load are occurring in the neck of the femur on the stance side when the heel strikes the ground? So the concave side of that neck of the femur is compressing or jamming up against. The convex surface is being stressed, being pulled apart, tensile stress. One side is being pulled farther from the other. Very dynamic effect. All right, moving on to tendons. The collagen fibers and tendons are nearly parallel. It basically is an extension of the muscle. All those extra muscular tissues, that fascia that surrounds the muscle, comes down, joins at the muscular tendinous junction, and creates a tendon. The properties of that tendon determine the amount of force that can be resisted. So how thick it is, how long it is, how much elastin is in it, all of that determines the amount of force that can be resisted. The most vulnerable place is where the tendon joins the muscle. The muscular tendinous junction is the most susceptible to injury because that tissue is changing its composition at that point. So you frequently get injuries at that muscular tendinous junction. As we put stress on our tendons over time, they increase in thickness and strength. So it's that Achilles tendon situation again. The Achilles tendon here, this is obviously a long-term runner. You can see how thick that Achilles tendon is. So they've really increased the hypertrophy of that tendon. All right, so ligaments. Very similar to tendons mechanically, but their fiber lays down according to the tensile stress. So the tensile force is pulling along the ligament. It's not always an exact parallel. So in this picture, the one on the left is the tendon, the one on the right is the ligament. So it's a bit jumbled. It's generally parallel, but a bit jumbled. There are some more cross links in there that give more support to the ligament. This more variable orientation makes them able to function in a range of load directions. So not just that pulling tension, but they also have a better ability to counteract stress See, shear forces. I need to walk. So instead of just pulling, you can get some improvement with a shear force, some control with a shear force. All right, I've been teasing about this, but now we're going to talk about stress and strain. Stress is defined as the internal resistance generated as the structure resists deformation, and then you divide it by its cross-sectional area. So it depends on the thickness of that structure. The area makes a difference. Strain is the increase in a tissue's stretched length relative to its original length. So stress is the amount of resistance to a force. Strain is the amount of change in that structure to that force.
Fantastic. I mean, that's just the equal opposite, reaction. So stress often can think of as just the load per square unit area.
Right.
The internal resistance is a function of that load. So it's sometimes easy, I think, perhaps to think initially that stress is load per unit area and strain is the result of that load.
Okay.
Internal resistance link, sometimes that kind of
confusing.
Throws people out.
Okay.
Maybe.
Yeah.
Whatever.
Okay.
Makes sense or not?
Yeah. We'll find out when we go to the graph. Or the chart, I mean. When the structure can no longer support that load or the stress, the force actually drops to 0, and that's when that tissue fails. So the ultimate stress is the stress just before the material fails. That's the ultimate stress that the tissue can handle, and the ultimate strain is the strain at that same point. So if you think about a TheraBand versus a rope, if I put a resistance, if I pull on a TheraBand, it has a much lower ability to, it's much less stiff than a rope would be. If I pull on a TheraBand, I have some give. If I pull on a rope, I have very little. So there's very little change in the length with the rope. So it's a lower strain to the same stress. Does that help? So a stress-strain curve can be developed with a tissue in mind. So a particular tissue can be stressed at 0 and 5 and 10 and 20, and then you can plot how much strain there is, how much difference in length there is based on that stress. And the stress-strain curve can be divided up into different categories. So the toe region is the first part where the slack is just being taken up. So there's no real resistance to the pull. It just gets taut or tight. That's the toe region. The elastic region, which is A to B on this chart, is how much difference in length there is with that amount of force. And it's a measure of the material's stiffness. So if you think about the rope compared to the TheraBand is going to have a much higher line than the rope. There's going to be very little change. No, I've got that backwards. Okay, so as I pull on the rope, it's going to have a much steeper line, and the TheraBand is going to have a much flatter line. Did I get that right? Okay.
There's a stiffer material that the break the.
Yeah, looks like that. Because the bottom is the how much change, and the y-axis is the force. Sorry about that. Anybody need me to repeat that? Or Ben to repeat that? Okay, so so your x-axis is how much change in the material, the length of the material. The y-axis is how much force I'm putting on that material. So if I take a rope and I pull and I do 10 and I do 50 and I do 20 and I do 100 pounds, I'm way up the y-axis, but I've only moved about a half an inch in length. Very steep curve. If I take a TheraBand and I do 5, 10, 15, 20, 100, right, I get the same amount of force, but I get much more difference in length from beginning to end. So that's going to be a much lower line. Why am I struggling with that word? Slope. There we go. The line that you generate, the slope that you generate, is called Young's modulus, the modulus of elasticity. So it's showing how much give there is in a tissue when a force is applied. And we call this stiffness of a material. So the rope would have a much higher stiffness than the TheraBand. So if we look further down this curve, we get to a place where the tissue can't be pulled anymore without some sort of trauma or permanent deformation. So in the plastic region, or in the elastic region, I can pull it and it goes right back to where I started if I let go of the force. That's the elastic region. That's typically where we function when we do, when we play in sports and that sort of thing, right? You want that tissue to bounce right back after you kick the ball or after you jump or run. There's a yield point at B where the elastic region ends and the plastic region starts, because now there's some change to that tissue that doesn't go back to where it was. There's a permanent change to that tissue that doesn't go back. So after I take the load off, there's some damage there. The more I pull on that tissue, the more damage there is, until the point where I get to C, and C is the ultimate failure point, where the thing just snaps, and then you have no response to the force because it has failed. So a sprained ankle, a sprain to your anterior talofibular ligament would be, if it's still intact but it's sprained, it would be in the B to C range. If you have a failure of that ligament, the ligament just plain ruptures, that's where you are at C, ultimate failure point. We don't want to be there. So like a grade 1, 2 sprain, would be in that plastic region. And I've had some people get confused because they think, but I sprained my ankle and it heals, and so I go back to normal again. So why isn't that in the elastic region? Once you have that damage, even though you can heal, you still have damaged it. So make sure you keep that distinction. So this is just another kind of way to look at it. This is an ACL from some research on ACL load. If you look at that toe region, the beginning of the curve, the crosshatch section, that's the toe region. When you learn to do a test for an ACL ligament, that's basically where you're functioning. You're not even deforming that ligament enough to get into the plastic region. So our clinical tests are typically done in the toe region up to the plastic region. That elastic region is where we are during play activities, so that's physiological loading, it's normal loading on the ligament, it's healthy for it. And then you get into that region where you start having some failure. the more force that's applied, the higher the force, there's more failure, and then ultimate failure. All right. Oh, this is beating this with a dead horse. So the clinical assessment is in the toe region. This is just the same thing we just talked about. So a grade 1-2 ligaments sprain, a partial tear is going to be in the plastic region. The higher the grade, the farther you are up the plastic, in the plastic region. And then a grade 3 ligament sprain is a complete rupture, so you're at point C, macro failure. Okay, so stiffness is a concept that is kind of hard to understand at times. So I wanted you to look at the two graphs that we have here. So the top graph, the ligament on the bottom is a stiffness, and the ligament on the top is twice the stiffness. So their length is not changing, but I've doubled the force. So the ligament that's twice as thick, or twice the stiffness, can take twice the load, but it doesn't really deform that much. Right? The length is the same. They can take twice the force. However, if I lengthen a ligament by twice, it takes the same amount of force, but it can lengthen twice as much. Right? So increasing the stiffness is going to just allow it to take a force that's a higher force, but it doesn't add anything to the length. Does that make sense? Okay, so what are the implications for compact bone being stiffer than trabecular bone? So stiffer. The compact bone is stiffer than the trabecular bone, or what does that help us with? Is it going to take more force, or is it going to take more? I don't know how to frame the question other than that. If a force is applied, is it going to take twice the force that it does, or is it going to take a more prolonged force? All right, so let's say it can have more force applied before failure. So the compact bone is stiffer than trabecular bone. So the trabecular bone with force is going to deform easier. So that helps us in a situation where we have an impact. So that compact bone is going to prevent fracture rather than the trabecular bone. But the trabecular bone handles strain better. So that's helpful, because if you think about where that trabecular bone is, we have a lot of it in the pelvis, we have a lot of it in our intervertebral, in our vertebral bodies. So it's going to handle more in the way of strain. So more prolonged. All right. And I had to leave this in for Dr. Schwartz again, because he talks about viscoelasticity and creep of tissue. And it matters when you get into manual therapy. So the rate of loading in a tissue matters when you go into doing things like manipulation and mobilizations. If you apply a force quicker, the slope is greater. If you do a prolonged load, then the slope is lower or less. So when you do a manipulation, you want to have a fast force because it has less ability to damage the tissue. The creep in the tissue is what causes a problem when you do manual therapy techniques like manipulation. But creep is also helpful if we do want to elongate tissue, right? So this is why we tell somebody to hold a stretch for 15 seconds instead of bouncing, right? You want to get the creep in the tissue, and a prolonged stretch does that. All right, there we go. That was for Dr. Schwartz. So when he asks you about it next year, tell him, yes, we talked about it. All right, let's just kind of go through the nomenclature with the joints, and we'll take a break. So the different joint types that we're talking about are based on how much movement we need at that joint, what their job is. We have synarthroses, which are very fibrously interconnected joints, very little movement. And then we have diarthroses, which are synovial joints, which give us the opportunity to move through space. The fibrous synarthroses have dense connective tissue holding them together, very negligible motion. So we're talking about the interosseous membranes between the tib-fib or the radius and the ulna. We're talking about the coronal sutures that hold our brain together, right? Thank heavens we don't have a lot of motion in our cranium. So those are the synarthroses, the fibrous ones. There are cartilaginous synarthroses also that we rely on. These have the hyaline cartilage or fibrocartilage, either one, very minimal motion, and they generally are in the midline of the body. There's not a lot of motion that comes from our the bones that are in the axis of our body. So your intervertebral discs and the discs of the SI, pubic symphysis, are the discs, the joints of the SI. So they're fibrous tissue. It is not your SI joint. Sorry, that's actually a different type of joint. So it's the intervertebral disc and the pubic symphysis. And they have a disc, and they provide minimal motion, but they do a lot of compression. They manage compressive force well. And that's really handy when we talk about what our spine has to absorb when we walk, when we jump, when we move. The diarthroses are the ones that we are more concerned about, just because we can do more with them. These are for movement. These are our synovial joints. There are 5 features that always have to be present if you have a synovial joint. It's not very often that we say always, right? So this is these are components that have to be there. So the joint capsule has to have 2 layers. The joint cavity is enclosed by a joint capsule. That joint capsule encloses the synovial tissue. And that synovial tissue has synovial fluid that bathes the joint surfaces. And the other aspect is the hyaline cartilage that covers the surfaces of the bone and gives us the freedom of movement. Lots of motion available in these joints. So when you lose the hyaline cartilage in your synovial joints, you end up with bone on bone, and that's very painful. That's what happens in arthritis. You've worn down the surface of the hyaline cartilage, bone is rubbing on bone. There's a lot of blood supply and a lot of nerve supply in bone, and so you end up getting pain. The different types. The diarthroid, you have uniaxial, which means there's one motion. You can hinge or you can pivot. The pivot joints are the radial ulnar and the atlantoaxial, the medial atlantoaxial. Those are pretty much it as far as pivot joints. We have several hinge joints. Biaxial are like the condyloid joints and saddle joints. So the condyloid joints have concave surfaces of one bone with a convex surface of the other. Frequently 2 degrees of freedom with these, so flexion, extension, abduction, adduction, typically. And you can see the radiocarpal and tibiofemoral. And then saddle joints, we're going to talk about these because they're more complex when we get into the arthrokinematics. So one side of the joint is convex concave, and then the other direction of the joint is concave on convex. So the motion is a little more complex. And by doing this, you minimize how much rotation or spin can happen in the joint. So it's a stability function. And then they're multi-axial. The plane joints, which occur between the carpals and the tarsal joints, these are 2 relatively flat surfaces that just kind of slide across one another. And then the ball and socket, your hip and your shoulder joint. All right. Does that kind of align with the language that Chad used or Dr. Howland used? Okay, so we're going to take a little break. Let's take a 5. That's probably going to be a 10. And we'll have somebody from your group come up and just jot what your project is down for me. I'd appreciate that.